permit me to praise the Lord. Praise the Lord once again. Praise the mighty Jesus. I'd like to say a big thank you to God for the grace to stand here. I was just telling mommy that it is not unto him that willeth or runneth, but unto God that showeth mercy. I am an embodiment of God's faithfulness. Mommy is an embodiment of God's faithfulness. We all are embodiments of God's faithfulness. All right, so mommy, thank you for this wonderful ministry. Uh, I just bless God for your life. And also thank you, Daddy, for being the major backbone, because they say behind every successful woman, there is a woman, there is a man. Behind every successful man, there is a woman. Thank you for being there for mommy. I'd like to say a big thank you to the entire DVD team. Mrs. Shore, you've been on my case. Thank you so much, Ma. I really appreciate you. Everybody for your presence here. I pray that the Lord will bless us today, and every information will be useful, and it will be to the glory of the Most High God. All right, so enough introduction. Let's quickly go into the topic of the day: unmasking breast cancer, education, early detection, and survival. All right, what is breast cancer? It remains one of the most prevalent health challenges confronting women and men worldwide. Don't be surprised. We get to see men with breast cancer. It's just that it's really rare, but we get to see them. It does not discriminate race, age, geography, although it disproportionately affects women in low and middle income countries due to limited access to medical care. All right. It is characterized by uncontrolled growth of cells in the breast. What did I say? Cancer can occur anywhere. It is not limited to the breast. Uncontrolled growth of cells in the breast, usually originating from the ducts and lobules or connecting tissues. Over time, these cancerous cells may invade nearby structures and spread. When they spread to distant structures or even the regional lymph nodes, we call it metastasis. All right. So, according to the Global Cancer Observatory in 2022, breast cancer is recorded to be 2.3 million new cases in 2022. Yeah, it is responsible for about 670,000 deaths globally in the same year. In Africa, breast cancer accounts for 25% of all cancers in women. In sub-Saharan Africa, we see lower incidences rate, like 22 per 100,000, but significantly higher mortality rates. You know why that happens? People don't go for screening, but they die. It's just we have a higher death incidence because they don't go to hospital, so they are not recorded. In West Africa, the incidence is rising steadily. In Nigeria, approximately 32,200 new cases are seen in 2025, according um, to the records. So we can have what we call modifiable risk factors and non-modifiable risk factors. What are the modifiable risk factors? Modifiable risk factors are the things we have power over. Non-modifiable are the ones we don't have any power over. All right? Like breastfeeding, it is breast cancer protective. It is a modified risk factor. Some women they say they don't want to breastfeed their children. But some of us, 2 years is standard for us. It's not easy, but parity. When you have more than one or two kids, it's protective because you get to breastfeed them. Then age at first pregnancy is always better when women start giving birth to children at early ages, in the mid-20s, you are done. Then previous exposure to radiation, we say due to mutagenesis, the cells may differentiate, and before you know what is happening, carcinogenesis, mutagenesis, there is cancer cells, everywhere. Then lifestyle. We're talking about sedentary lifestyle. We don't do exercises. We smoke. We take alcohol. Obesity doesn't help anybody. Those fat cells, on the long run, they can turn around and turn to cancer cells. Smoking, smoking and alcohol, they're just two terrible things that people enjoy. But unfortunately, they're dangerous to our health. Even though the Ministry of Health tells all the companies to put it there, but people still do what they like. Alcohol, it doesn't help anybody. Then dietary support. We're talking about hormone replacement therapies. You see, for breast cancer, just in prostate cancer, breast cancer, the ones that are hormone receptor positive, the estrogen receptor is a fuel for the cancer, just like testosterone for prostate cancer in male. For the ones that are more receptor positive, if you are able to curb the level of estrogen in the body, you have a good control. So, which is why for our women that say, okay, they want to take estrogen replacement therapy, particularly the postmenopausal, we know that our female sex hormone, the feel good hormone in women is estrogen. When the level goes down at menopause or perimenopause, we become tired, begin to have bone pain, you don't want to do anything, hot flushes. And some of the doctors out there, they just recommend estrogen replacement. I tell my patients it's not safe. Or hormone embedded IUCDs. It's better to do away with those hormones. So we can work on those ones. We have power over them. But the ones that we cannot, you don't have any power. Talk about the female sex. You are female. You did not make yourself. You know that the fact that you're a female, anything can happen. All right? The African race, African American, Hispanic, we see it in us. And when we see breast cancer in us, they usually are aggressive. May God help us. Then the genetics, talking about the BRCA gene. I don't know if you all know the popular American actress Angelina Jolie. She made the breast BRCA gene very popular by going to do mastectomy. She removed the breast. They did a genetic profiling and realized that she had the BRCA gene, which is responsible for some breast, ovarian cancers. And so she did not want to have breast cancer. She did not have it at that time, but she just went to remove. And I know some patients that after the diagnosis of breast cancer, they just go in and do a oophorectomy, they remove their ovaries because it's not just in the breast that these hormones are there. So the BRCA genes, it helps as well. Positive family history. You cannot create yourself. You can't choose the family you're born into, so you don't have any power over it. What do you do? Once you know you have a positive family history, everybody has to be at alert. If there's been breast cancer in the grandma or in the one that's even was his immediate family members, so you have to start screening on time. I tell my female patients, your daughters, your sisters, please send everybody start screening. If they are less than 40, start doing ultrasound scan, you should know the normal from the abnormal. All right. Then some certain benign conditions, we call them fibroid adenoma. We see them in young women. I've seen it older adults too. When you begin to call all the time, you've gone in, you removed it. Again, you've gone in, you removed it. I've seen a patient, a young patient, a 21-year-old lady who had fibroid adenoma, and they removed it in less than a year. It came back again. And she just assumed it's fibroid adenoma. And she left it. Lo and behold, it was a triple negative breast cancer that she had. The thing grew to the size of an egg. And when we went to biopsy it, I said, why don't you just biopsy again? We biopsied and it was triple negative. Unfortunately, it was close to the chest wall. So it was a tough battle to be able to control that disease. All right, so history of breast cancer. I mean, you've had breast cancer before. You can still have it in the other breast. All right. So you should be at a level. Not everybody doesn't be occur in everybody. Some people are cured, and I pray that our mommy is cured completely in Jesus' name. Affliction will not arise again. And as many as are here, we will not be patient. At our adventure, we have loved ones. going through this situation, the Lord will perfect your healing. All right, so personal history of endometrial ovarian cancer. I was talking about the genetic. I was talking about the BRCA genes, some family, some Lynch syndrome. There's some syndromes. You see them, they have prostate cancer, they have colon cancer, they have breast cancer, they have ovarian cancers. So all those kind of personal histories, may God help us. There's some breasts, they have high densities. It's not your fault. You see some breasts, they're like yam. Some breasts are like water. The one that is like water is soft, you can easily detect anything. But those ones, you cannot determine the kind of breasts you have, you know. So some things can hide there. So you need to be more proactive to go and be checking all those. Then age greater than 45 for white race, less than 45 for black race. Excuse me, I have seen 16 years old with breast cancer. I have seen 19, I have seen 20, I have seen 30. So it's just by God's grace. Like I said earlier, it's God unto God that showeth mercy. May God will help us. So types of cancer. Cancer can arise, breast cancer can arise from the ducts that carries milk in the breast, or from the lobules that holds the milk. All right? And you can have mixed tumor breast cancers. It can arise in the duct, or it can arise in the lobules, you know, or even some in the connective tissues that holds the breast, indeed in the fat that holds the breast together. May God help us. So types of breast cancer. You have the non-invasive type, all right? You have the invasive type. The non-invasive relies on the ductal carcinoma in situ. I mentioned where it can arise from. If it arises in the duct, if it arises in the lobe, in the duct, which is the commonest, or the ductal carcinoma in situ, I mean, the cancer is just confined within the breast ducts. The patients are lucky to catch it. They just go in, clear everything, and patient is fine. Just small follow-up treatment, right? Or they have invasive lobular. If it arises in the lobus, it's just abnormal cells just confined in the lobus, not yet cancer, but a high risk marker. But we sit on those cases. Some patients are, and you know the funniest thing, I've seen some cases that they said, oh, it's invasive, just ductal carcinoma and lobular. And before you say Jack and Jill, misdiagnosis, cancer is everywhere. But when I see it, even if it's invasive lobular or doctor, I am sitting like mother hen on that case, you know. So the infiltrative type, we have the invasive ductal carcinoma, which accounts for 70 to 80% of cases globally. It begins in the duct and spreads. We have invasive lobular, I mean, it begins in the lobus, comprises of about 10 to 15. Then we have the other types. We have the tubular, those ones are not common. The mucinous, the medullary, then inflammatory. Inflammatory is not good. It acts like a breast sarcoma. You see the breast in a short while, the breast is like orange peel. So they're not really good, but God will help us. So I'm sure we've all heard about molecular subtypes of breast cancer. Nobody can manage breast cancer well without the genetic profiling. It's like saying you want to catch someone and you need to know their mother's name. If you don't know their mother's name in the spiritual realm, that's why it's not good to just be careless about information out there. Once you know the family where they come from, you can attack them. This is the same situation with breast cancer. So we're talking about the molecular subtype. If you know it, that's why you cannot manage breast cancer without knowing without knowing the molecular subtype. If you know it, then you can know the right thing to treat. I can have in a clinic like 3 or 4 patients be seated, and they have different treatment plans. Some may be hormone receptor positive, some negative, some triple positive, some triple negative, some HER2 positive, some not even having anything at all. So the treatment approach will be different. So if you have people that have breast cancer, you will ask them, or they are treating them in one private hospital, have you done your immunohistochemistry? Because that will guide the doctor on how to treat specifically. So now, just let me just run through this. I know I don't want it to sound too technical. So we have the lumina is high. Where we have the estrogen receptor is positive and or PR positive, but HER2 negative, it has a low Ki67. All right. What do they mean by the low Ki67? That tells us how aggressive the disease can be if it can spread. So it's the most common cancer type globally and typically associated with the best prognosis. All right. We use the immunohistochemistry for prognostication and also to guide us in the choice of treatment. In Nigeria, Lumina A is prevalent, but may be underdiagnosed due to limited access to immunohistochemical testing. You'll be surprised in this day and age that we're doing this step. Some people are still in some hospitals just treating breast cancer blindly. So we all need to stand in and do our bit. So we have the Lumina B type. The estrogen receptor is positive and or PR progesterone receptor is positive. It may be HER2 positive, all right, with higher Ki67 index. This is really very aggressive than Lumina E and requires combined endocrine and targeted therapy. All right. Anytime you hear HER2 positive, it's a bit expensive to manage because we need to bring in targeted therapy to, I'm sure some patient, I was in clinic last week and I got a call from someone and they said from the Ministry of Health that they said the patient came to my clinic and they said the patient will need about 28 million or thereabout. And I said, okay, 28 million. I think they said, can it be expensive like that? I said, no. Their breast cancer are different. It depends on the type the patient has. I said, okay. So do you know if they mention if the patient is HER2 positive? I said, okay, say what drug? They said, first go. I said, oh, the patient is. I said, mention the drug on the prescription. First go. I said, is HER2 positive. So I said, we can do dual blockage or single blockage. Usually we prefer to do the dual blockage. The loading dose of that drug is almost 2.5 million. And the maintenance dose is about 1.8 million every 3 weeks. And you can imagine taking that for 18 good times. So it's a lot. And guess what? You have a 99% chance of complete pathologic response, all right, if you use that drug, which is why that immunohistochemistry has to be done. So it can really be pricey to maintain. So for the Lumina B type, they have to combine hormone receptor blocker and targeted therapy to treat. So we have the HER2 enriched type. I mean, for this one, it's just the HER2 receptor that is there. All the estrogen receptor, endocrine receptors are negative. So this one tends to go fast and may respond well to targeted therapy, like trastuzumab or in combination. So in Nigeria, this subtype is often diagnosed late, making targeted treatment less effective. As a matter of fact, generally, early presentation saves lives. So triple negative is also common where the estrogen receptors are negative, progesterone receptors are negative, HER2 receptors are negative. It's common in women and African descent and often overlaps with triple negative breast cancer. Guess what? This is very difficult to manage. It is difficult. It's a doctor's nightmare, all right? Because you don't have any receptor to block. After giving chemotherapy, I mean, at least if it's hormone receptor positive, you are still blocking something. If it's HER2, you are still blocking. But with triple negative, it's common in African or women of African descent, and it occurs in younger people. It's difficult to manage, but we win some. We win some. It's not that bad, like I said. So, what are the rates of breast cancer? I'm sure you've been seeing when they put this to pathology report, they've taken sample, sent it to the lab. Oh, now we're seeing it's breast cancer. Now we're talking about, they put it there. Invasive ductal carcinoma, SBR, grade 3, grade 1, grade 2, grade. So, interpretation of these grades, what it just tells us is it indicates how much the cancer cell resembles normal cells. I'll just run through this. Grade 1 is low grade. Grade 2 is intermediate grade. Grade 3 is really aggressive. And what does that mean? That grade 3 can quickly spread around. Apart from the type of the breast cancer, in terms of histopathology, invasive or ductal carcinoma, the grade of the disease is also very important because that also tells you how aggressive that disease is. And the immunohistochemistry, those are the three major parameters that we look at. So intermediate, I've mentioned, not so aggressive. I'm in between. I'm not gentle. I am not wicked. But the grade three is the one that is really over there. So the moment we see it, we'll just make sure we do an conclusive and inclusive package. So what are the stages? I'm sure we've heard some patients will come. So what stage, or when relatives come with the patients, so what stage is this disease? What stage is this disease? I mentioned earlier that we have the ductal carcinoma in situ, we have stage 0, we have the ductal carcinoma in situ, we have stage 1 where the cancer is just less than 2 cm, all right, less than 1 cm in that area, all right. So stage 2 is when it's is more than 2 cm, 2 to 5 cm, all right. It's greater than 2 cm and it's still in the breast. But it may have gone to the axilla when we start seeing it in the armpits. That's about the stage 2 disease. But when it now become larger than 5 cm, we have larger nodes in the armpits. That's a stage 3. Stage 4 is when it's now gone beyond the breasts, it's gone beyond the armpits, it's gone to distant organs. And what are these distant organs? We have the lungs, you have the liver, we have the bone, we have the brain. Those are the major areas that it can spread to. In terms of other malignancies, we can have spread to the peritoneum, intra-abdominal cavity, or the structures that are there, the omentum and all that. So, in terms of survival rate, stage 0, like all those doctor carcinoma, we have survival rate is about 100% in terms of stage 1, which is why early presentation, screening, showing up for testing and all that is very important. So if you catch it at stage 1, survival rate is about 98%. If you catch it about at stage 2, is about 88%. Stage 3, survival is about 52%. And the stage 4, survival can be about 16%. God will help us. So what are the breast cancer symptoms of early breast? What do we notice? We can notice it's always good to know the normal from abnormal. I mean, you should know what your breast looks like. So the moment you see something that is off, you can quickly pick it. Your armpit, the breast, how do you check? The four quadrants, inner, upper outer, lower inner, lower outer. The armpit, you look up here, down, laterally, up and down. So you should know what is happening there. So what are these common symptoms? You can see lump in the breast, or you may not even see any lump in the breast. It may be in the armpit that you notice a lump, all right? Or you can see discharge from the nipple. Somebody that is not breastfeeding and you're suddenly seeing discharge, and that discharge can sometimes be bloody. Dr. Leticia, it can sometimes be bloody. My friend, who is a nurse in the UK, her mom received the COVID vaccine, and after 2 weeks or thereabout, she said she pressed the nipple. I think, no, it wasn't. She didn't press. She wore a bra and she wore a white bra and she went to sleep in the afternoon. By the time she woke up, there was blood all over and she was wondering what caused it. So the doctor is a nurse. So she said, Mommy, that's most likely a cancer. She did not even mince word. Mom said, No, why can you say that? I said, Mommy, let's go and test. And lo and behold, we found a lump hidden somewhere. It was cancerous. So some may see lump, some may not even see lump. Then we talk about the dimpling of the breast. You know the orange peel. You know how the orange peel is dimpled. The peel of the back of the orange, you see dimpling there. Some patients can just notice, what is this? Or is even you may not even see a lump, maybe a generalized swelling of the breast. Some patients will tell me, Doctor, I started feeling heaviness on the breast, and it wasn't. I thought it was my ovulation related, but it wasn't. It was getting bigger. I thought it was period. It did not. You know, there are sometimes in the month, in the cycle, that the breast fullness will be there. You are not pregnant, ovulation came and went by, period came and went by, it's still like that. You need to run. So some patients may just be dull aches in the breast. Not all aches are cancer because mid-cycle you can have tenderness around the breast. Towards the period, you can have tenderness, and when even pregnancy, early pregnancy, you can have tenderness. So not all tenderness is cancer, but you need to know the normal. But you can ask people, the healthcare workers, to check so that there won't be any stories that touch the heart. There may even be redness. I mentioned the swelling of the breast. There may be redness or change in shape of the breast. There's something they call auto amputation. The first time I saw auto amputation, I was so upset. I'm saying, Madam, what were you looking? The breast with the shape, it lost its shape. The breast retracted itself, went inside, and it was as if the breast was. I said, what? They said she did not know. I said, how can you keep something like this? So there may be change in the architectural structure of that breast. So please let's be aware. So early detection, why are we here today? Early detection, we're trying to talk about early detection, not just to talk about the disease, the harmful things it can do. Early detection, it saves life, the life-saving tool. Significantly, it improved the chances of successful treatment and survival. I mentioned the percentage of outcome, survival rate percentage. I mentioned that if you catch it at stage zero, stage one, then imagine catching it. You know you can have 100%. Then imagine catching it at stage four, when you know that survival rate is about 16%. It's not a good one. All right. So the key lies in recognizing symptoms and conducting regular screenings before the disease progress. All right. And that's why I mentioned earlier. So methods of detecting of early detection, breast self-examination. I kind of digressed into it earlier. Knowing the normal from abnormal. What is the shape of your breast? Breast shapes are different. Some patients have seen long breasts, wide breasts, pendulous, all sorts of shapes. You should know what is normal. Breast self-examination. It involves checking for lumps, the skin. Is there any change in color of the skin? Is there any redness anywhere? It's like I said, they may not even be lumps. One woman said she felt like a plaque. A plaque. When we checked it out, we they checked it out and it was malignant. God will help us. So know the normal from abnormal. Check for lumps, change in skin color or nipple. Is it nipple deviation, retraction? Is there any discharge? All right. You know what it feels like. This empowers women with awareness once you know what is normal from abnormal. Then the clinical breast self-examination. This is going to be breast examination is going to be performed by the healthcare providers, nurses. They are trained to do this. Doctors are trained to do this. They check from quadrants. They check the axilla. They do all the necessary things. I mean, this should be done annually for my A20. The clinical examinations. Then talking about mammo. Mammogram has always been there. This is the use of X-rays to image the breast. Is recommended annually or biannually from age 40. In ladies that are less than 40 years, we advise that they do breast ultrasound scan. The mammo, the breast ultrasound scan will look at not just the breast, the entire axilla, the network of lymphatics, and all that. The more advanced imaging is the breast MRI. No matter how tiny that lesion is, the MRI will bring it out. All right. Now, if it picks even more than I've seen situations where a mammo did not see the lesion, but MRI picked it. The patient kept saying that she's having one striking sensation. 1 second, I'm like, we cannot feel, we couldn't even palpate it. But she just said something was happening in the breast, and she went in for the MRI, and really tiny. So we had to do ultrasound guided biopsy of that tiny little thing. Guess what? It was sinister. It was just waiting there. I think God just showed that woman mercy, and she was able to catch it early. All right. So MRI often recommended for high risk individuals. Who are the high risk individuals? What is the family histories? You know, personal family history of cancer, first degree relatives. If they have the funds, it's a bit expensive, but you encourage them to go for it. Survival rates reflect both healthcare access and early detection. Globally, high income countries, they have 5 year survival rate of 80 to 90% for early stage cancers and late stages, talking about metastatic, survival drops about 30%. In Africa, general survival is about 40% due to late diagnosis and poor treatment. In that my oncology clinic, I have seen monster cancers. I have seen humongous lesions that even me as a doctor, I'm bewildered. Where have you been? People fear stigmatization, they fear people knowing. There is no excuse for ignorance. I just tell them point blank. And their relatives that are there, I say, you people are wicked. You've been looking at this woman. I say, is this your husband? And you've been sleeping with this woman. Did you not see this? Can't you just make, even if you don't have the funds, raise alarm, escalate it. People will come in. I say, some women will hide it though. It is when the smell starts disturbing them. I saw one when I trained in Luz. There was a case I saw, I will never forget that case. The breast cancer ate the chest wall, and you could see the heart underneath. And she had a husband. Ah, we fought that man. No. We lost her because he kept her in the house. Even the woman too. I said, even if your husband cannot, do you not have relatives? Do you not have neighbors you can shout to go and meet? So the man will keep her in the house was until the smell was becoming too much. Imagine watching your wife or your husband rotting away there. It was a sad experience. But this could have been avoided if this patient had known the normal from abnormal, or she probably knew she was afraid of stigmatization. There was a time I went to a pharmacy in Ajawo Estate. I was passing by just, no, it wasn't Ajawo. It was Iriakari Estate. I went to consult in one of my colleagues' hospital. And when I needed to buy a medication for my son. So when I got in, I saw one woman, I saw that there was abnormality. She was one of those auto amputated cases. This place was big, this one was down. I just walked up and I said, Madam, it looks like you have breast cancer. She looked at, I said, yes, I can see something ongoing on your chest. I said, Madam, please, I'm sorry to barge into your privacy, but this is what I manage. This is my number. Can you come and see me in clinic? We all can be advocates. We see something that looks abnormal, and you, Madam, this is not normal. I know the number of people I've seen, and your next wedding, I have colleagues that bring it up like pure water. Dr. Mahmoud is very good at that. I said, this thing I carry is load. Let me give you my colleague's number. He's very good. Go and meet him. And he will go. Even in church. My mom's church, when we did my dad's remembrance, I saw one of the officiating ministers. I went to meet the pastor, the lead pastor. I said, sir, I know a colleague that can do this thing. And that can remove the thyroid. And he went. He said, Doctor, thank you. And the guy did it. He started looking for me to thank me. I said, no, all thanks to God, I've done my bit. So we all should be advocates. All right? So, preventive measures. We have the primary prevention, which is all about reducing the risk. We maintain, these are the things we can do by ourselves. We maintain a healthy weight, a high BMI. You see, some of us, our mouths don't put us in trouble. We don't suya. All those fatty meals, cheese, butter, pizza. I don't want to talk about Domino pizza. I will tell them to use double cheese. And my colleague said, Olat, you know that thing is not good. It's not good. It's not even good for you. How much we are still requesting for double cheese? We are guilty. So we should take cognizance of that. Maintain a healthy weight, healthy lifestyle, no alcohol, increase your physical activity. If you cannot run, if you cannot walk, there are these simple vibration machines that are everywhere now. You can just buy them after work, mount the machine, and the thing will be vibrating your entire body. By the time you spend 30 minutes or 1 hour on that machine, you've done a lot. If you can walk, it's healthy. Walk around in your estate, burn fat, burn energy. You little or no consumption of alcohol. I'm an advocate of no alcohol, no smoking. But some patients will say, no, we cannot do without it. Even if it's tiny, it's not say red wine is good for the heart. I said, everything in moderation. If you can do without it, please. But if in moderation, but smoking, no smoking at all. Avoid hormone replacement therapy. I talked about it the other time. Like when you're in menopause, doctor says, oh, because you're having not flushes your time. And it's better to endure all flushes. It's better to endure tiredness. If your calcium is low, we use calcium. Eat healthy diets, you'll be fine. Now to go and take estrogen replacement therapy that will cause problem. I've seen situations that even the nut plants that they use, all those contraceptives, I've seen 3 young people that came down with breast cancer while they were on that nut plant. Avoid anything hormonal. I won't lie to you. The safest contraceptive is abstinence. If you cannot abstain, copper tea is safe. Copper tea is safe, very, very safe. Not the one that is embedded in hormone. I know what some of them at the IUCD, some of them have hormone around them. So if you can avoid those ones, please do. All right. Breastfeeding has always had a protective effects. I mentioned it earlier. If you breastfeed for 2 years, it's safe for you. All right. Genetic testing, counseling for BRCA mutation. I gave us a story of Angelina Jolie earlier. It was just genetic testing she did. She had positive family history of cancer. She went to do genetic testing, and voila, she escalated. Everybody now knows about the BRCA gene, and Angelina is she's there doing her thing. So coming to secondary prevention, early detection. Don't forget the primary prevention is reducing the risk, doing what you can. Then the secondary prevention is early detection. It's community-based education, what we're doing here, what God is using our mommy to do, the entire DDD team. The routine breast health examination, the clinical breast examination, the health checks, accessible mammo services. I mean, these are secondary prevention. And the tertiary prevention is reducing complication. Once you make a diagnosis from the secondary prevention, early detection, prompt treatment, prompt diagnosis, multidisciplinary team treatment. Cancer management is multidisciplinary, multimodality. What am I talking about? All the specialists to come together, make a decision. Before I can sit comfortably, a surgeon would have taken a true cut biopsy, a pathologist would have processed the slides to give me diagnosis, all right? And I, as an oncologist and with dual qualification, radiation and clinical oncology, I will say the patient with that result, oh, I have a diagnosis, I will run with it, with the immunohistochemistry as well. Oh, what am I going to do if it's a late stage 2 or stage 3? I quickly downstage the treatment with chemo and targeted therapy if there is need for it. And if I have to do surgery, I revert back to the surgeon. Oh, surgeon, please, I've downstage this disease with neoadjuvant chemo. Please kindly go ahead and do the surgery and send the patient back to me. Once the surgery is done, because I know there was axillary metastasis that I downstaged to like a stage 2 to remove the lesion, to remove the breast and clear the axilla, or maybe a conservative surgery was done. Return this patient back to me. I would send this my patient again for radiotherapy, for localized control. All right. And if I'm supposed to, if it's hormone receptor positive, I will continue on hormonal therapy, even while the patient is on radiotherapy for 5 to 10 years Radiotherapy is just for 3.5 weeks. The patient is done. And if it's HER2 positive, I'm going to continue on HER2 receptor blocker, the likes of the single blockade, Herceptin, or the likes of the dual blockade, the Herceptin and Perjeta. Patient will take that to a maximum dose of 18 cycles. That's about a year. All right. So it is a team effort, not just one person. Nobody can just sit in a corner and say, I'm treating, but it's everybody's effort. So after we're done, long-term follow-up and rehabilitation. In some patients, their mental health is shattered. Particularly if you don't have the family support, the ones that the likes of our mom received. If there is no, I get to see them. Some people don't have the family support. There's financial constraints, and it's a huge burden. It's a huge burden. Their mental health, the mental well-being is messed up and all that. So it takes a lot to rehabilitate. You just keep encouraging them. We're more than doctors, even psychologists and all that. So they come to us, they are free to open up and talk about everything. I talk not just about medical things, family. I've seen some patients say the husband will say, breast cancer is contagious, don't come near me. No more intercourse. I've seen some people, the husband will the husband left them and went to marry somebody else. Or so all those emotional problems. Imagine having all those emotional problems with the health problem. So it's a big one. So you need to break everything down and keep encouraging the patient that, oh, life comes first. So how many kids do you have? You have to live for your children. You have to be there for them. We have to be encouraged. We have to do this. Madam, this is a race that we are running together. We have to be positive all through, and God will see you through. So it is everything: spiritual support, physical support, financial support, emotional support, psychosocial support. Everything comes to play. We have to bring everything to the table. So we encourage them so we don't lose them to follow up. Some patients will just default. I've seen situations where patients, you downstage the disease and you tell them, Madam, the next thing is to do surgery. They don't take off. And come back 2 years later or 1 year later, they are confined to wheelchair, they have brain metastasis, there's fluid in their lungs. That situation, you cannot do anything again. Or even if you say, okay, I will not look at the patient die, I will watch the patient die like that. You still want to do something, but like in Yoruba, you just try to do your best for those patients. So we encourage them so that you don't run away. So you have to be personally there for them. Madam, don't worry, this one and that one. So we give them all the support, give them good rehabilitation, psychological and palliative care in those late stages. All right. So what is my take home message today? Early detection saves lives, improved access to treatment improves survival. Thank God for this awareness we're doing in Nigeria and West Africa, where late stage diagnosis is rampant. A renewed focus on awareness, affordable screening, comprehensive care is critical. Breast cancer need not be a death sentence. It can be survived if found and treated early. Thank you so much for listening and for the books with impact knowledge. So I will await questions and